Hi, my name is Dr. Wayne Dobbins, and I'm a board-certified orthodontist and pediatric dentist here in Overland Park, Kansas. And the name of our practice is Sweet Tooth Pediatric Dentistry and Orthodontics. And today, I wanted to talk about and present a few things that we've been getting a lot of questions about, both on social media, both in person with parents, and a few things that I wanted to cover. I have my notes here, a list of things that we've been getting and how I want to present that and answer those things. First is, should your kids be visiting the dentist, pediatric dentist during COVID, or the orthodontist during COVID? Is it safe? And then what is our office doing, or what are dental offices, what they should be doing to keep kids and parents safe? And dental emergencies, what to do, what constitutes a dental emergency, when should you be calling my cell phone at 3 in the morning or on a weekend, and when should you not worry about it? So, like I said, I'm a board-certified orthodontist and pediatric dentist, first-time vlogger, but all that means is that I just went to a lot of school, went to 2 residencies, both orthodontic residency and a pediatric dentistry residency, and just wanted to take a little bit of time here to talk about children's oral health, and I'm happy to be here with you. And I wanted to thank the KC Moms Collective for the opportunity to speak with you and about children's oral health and what it looks like in this post-COVID world. So, a little bit about me. I'm actually from Arizona, outside of Phoenix. We call it the East Valley, from Mesa, Arizona. I got my bachelor's from Arizona State University, did my undergrad there in biology, and went on from there to the University of Buffalo Dental School, and became a general dentist, and went immediately into my orthodontic residency out in Oklahoma. So I went from Arizona, where it's hot, to Buffalo, where it's extremely cold and lots of snow, then to the Midwest, just south of here in Oklahoma, and then I practiced here in the Overland Park area as an orthodontist, and also up in the Legends area, and then I attended a pediatric dental residency, which is part of the NYU program. I was actually in Providence, Rhode Island, as part of that pediatric dental residency. And then I came back to the Overland Park area, to the Kansas City area. And we're super excited. Been here over a year now, and it's been awesome. It's been awesome. I always say that the West Coast has the best weather, the East Coast has the best food, but the Midwest has the best people. So yes, I am practicing both pediatric dentistry and orthodontics here at Sweet Tooth Pediatric Dentistry and Orthodontics. And it's awesome. It's awesome. And the two just play hand in hand into one another. As an orthodontist, practicing orthodontist, I saw so many things that could have been avoided early on if pediatric dentists or general dentists had known what to look for. But frankly, you don't know, because the training is so different and individualized. So my brain is turned on to both. And so I'm looking for things that neither pediatric dentists nor orthodontists alone are looking for. And it's an awesome way to practice and to treat patients. I am only one of 2 in the entire state of Kansas to have those certifications, which again, doesn't make me better than anybody, but just means that I went to a lot of school, and I practice in a way that allows me to look for things that other people aren't necessarily looking for. Just before we went to school, I married my wife, Rachel, who has been there with me the entire time. And when I say going to school, I mean undergrad. So I got married, I was 22 years old. And so during our undergrad time, we were married through dental school, through orthodontic residency, through working here, through pediatric dentistry. So she's been with me the whole way. She is the most understanding, caring, supportive person, and I could not have done this without her. I wanted to talk to y'all, the KC Moms Collective group here. talk about some of the kids' dental precautions, the myths, the best practices, and recommendations in 2020. So please feel free at any time to PM me at Sweet Tooth PDO, Pediatric Dentistry Orthodontics, at Sweet Tooth PDO, and I will, of course, get back to you just as soon as I can. But what does it look like today going to the pediatric dentist and the orthodontist, and what should you be looking for, things staying safe, because it is a crazy time. So I think the first thing I would say is going to a general dentist versus going to a pediatric dentist. What does all that mean? Well, the approach is different. The philosophy is different. A pediatric dentist went to 2 additional years of school after dental school, and all they did was work on kids 18 and under. Lots and lots of younger kids, lots and lots of kids 12 and under, but lots of kids 18 and under. And the best difference that you can think of is a family practice medical doctor versus a pediatrician. Same scenario versus a general dentist and a pediatric dentist, where the pediatrician went to additional years of training. Pediatric dentist also went to additional years of training. And so we're geared to think about different teeth, different way that you treat teeth, baby teeth or primary teeth versus the adult teeth. Trained to understand the behaviors better, how to work with those behaviors, the philosophies behind those things, what works well, what we know doesn't work well. So the question right now that a lot of people have is it safe to go to the doctor or to the dentist? And I would say that you've got to look at what your doctor or your dentist, pediatric dentist, is doing. And are they following, like I mentioned, the CDC guidelines, the ADA guidelines, the AAPD guidelines, which is the American Academy of Pediatric Dentistry. And what are they doing? So a few things that we are doing, what we have implemented, are these recommendations, and I'll share that with you. First thing we're doing is we're conducting a health screening before you enter the building. We have you fill out how are you feeling? Are there any flu symptoms? Have you been exposed to anybody? Where have you traveled? So you've got to pass that health screening first, and if you answer yes to any of those, then we reschedule you at that time 14 days out to be able to come back and pass that health screening. The second thing is temperatures. Are temperatures being taken on both the child and the parent? We do that. And if a temperature is over 99.9 degrees, then we reschedule the appointment. And are accompanying adults required to wear masks? We do require that in our office. We also require kids to wear it at a reasonable age. And do we see patients that are sick or have had flu symptoms or flu symptoms in the last 14 days? The answer is no. We reschedule that as well. Is the area, the seating area in the clinic outside where patients wait, is that arranged in such a way to encourage social distancing? And in our office, we've done that. We've put 2 or 3 seats apiece, more than 6 feet apart. We've even have chairs outside of the office in the foyer. We're in a medical building, and so we have it in the foyer for those that would really like to social distance even more. We have that as well. What protocols are in place for heightened cleaning, hospital-grade cleaning products? Dental offices in general have always used hospital-grade cleaning products, for example, such as Cavicide. We use Cavicide still. We also have integrated a new product called Optim 33 TB, and it's an awesome product. It cleans or really disinfects even faster than Cavicide. It's for 1 minute instead of 3 minutes, so everything is wiped down completely in between patients. We have additional protocols for our own team, washing hands in between all patients. Our own employees, our own team, are not allowed to have masks off at any point during the day. So even within our own team, we do not allow one another to be exposed to one another, as the CDC has defined that in their guidelines. What else? Cross-contamination, aerosol abatements, protocols in place. In pediatric dentistry, we are not using Cavicides. Cavicide is the air that will come out of the tip on the instrument when you're cleaning your teeth, and that is used in general dental offices for deep scaling and root planing. Hygienists use those. We don't use those here simply because we don't have that need. You know, there's 4, 5, 6, 7, 10-year-olds don't have that buildup of calculus and periodontal disease for big pockets and for calculus to go way down. When we're doing any kind of cavity adjustments or removing cavities, we use a high speed and a slow speed, and that does have water that sprays. But we use that in this room, such as this room right here, where it's isolated from everyone else who's here just for hygiene. Hand sanitizer, it's readily available. We have one at every single unit or operatory bay, we call them. We've got it outside in more than one area. So it is readily available for anyone and everyone to use. And yes, all of these rules apply to our staff. And again, told you a little bit about that. We have even a higher level of requirements for our staff. Most medical practitioners now are much more vigilant even than they already were. So we do let adults accompany the children so long as they have a face covering, or face mask, or a face cover. They're allowed to be in here with them. The only exception for parents being able to be in the room is on anesthesia days, general anesthesia days, sedation days, behavioral concerns or issues, things that children do better with parents not there, or we have an entire team of other doctors in the back as well, and there's just not enough room, so a child's going to sleep, something like that. I have been asked, is it okay to push this off, our 6-month cleaning, to the next year, to 6 months out, to a year out? And simply, I wouldn't recommend it. I think the recommendations are there in place for a reason, to be seen every 6 months. I have seen teeth that we are watching, and this is just recent. I can think of some last week, teeth that we were watching from 6 months ago that have now become big cavities, and such big cavities that we can't do a white filling on it. And that's simply because there's so much of the tooth structure that's gone that the white filling won't stick. It won't stay. And so we have some other alternatives after that point, but and that's a rare case, but I'm just thinking of something that's extreme in that sense, that we want to be able to see these things and follow these teeth. But again, it all comes back to your comfort level, to mom's comfort level, and you're going to do what's right for your child. My whole point here today is just to say, hey, we're doing everything that we've ever done, and we put extra layers of protection and helping you feel safe and secure bringing your child. We don't want you to miss your appointments because of fear, because of not thinking that things are clean. Again, you will make those decisions for your family, and everyone is processing this whole thing in their own way. And so we're going to be respectful of that, and we understand where everyone is, that everyone's at a different place with that. But we're doing everything we can in our power to make it safe. And I think we're doing a fantastic job at that. We want to be able to catch things early. We don't want them to grow, because as soon as that cavity gets through the dentin, there's 3 layers. There's the enamel, there's the dentin, and then that 3rd layer is where the pulp tissue is and the nerve. And as soon as that cavity starts in the enamel and gets through the enamel into the dentin, it goes fast. Now, when it's in the enamel only, we don't have to do anything. You do not have to fill a cavity when it's in the enamel. It can actually remineralize. But once it gets through into the dentin, boom, now it goes 3 times as fast as it was in the enamel, and so it can really go really quick. So that's some of the things that we like to do, that is being able to just kind of watch for those things and talk about what kind of toothpaste you're using. Should you go from training toothpaste to now having a little bit of fluoride in the toothpaste? What kind of diet is there? What to look for? All of these things. So the AAPD, again, Academy of Pediatric Dentistry, suggests every 6 months, and they still suggest every 6 months, even with this pandemic going on. And so I defer to them for that, and we follow their protocol. On the orthodontics side, as a board-certified orthodontist, we're thinking about growth and development issues, growth and development problems, things we want to catch early. If turning to the side, the jaw is way back, that's called a retrognathic mandible. If turning to the side, the jaw is way forward, that's called a prognathic mandible. Things like that. Or on the inside, are the teeth super, super crowded? And is there anything we need to do? No, not always. A lot of the times, if it's just crowding, the teeth are not straight, but we call it crowding like this, you don't need to do anything. There would be no benefit to doing it early on versus waiting when the child is now a teenager. Not only do you save money, which is important, not having to do 2 rounds of orthodontics, but it's just not necessary to put you through that many trips to the dentist and time and everything else. So it's not always something that has to be done, but watching for those growth and developments, the expansion of the mandible, making sure things aren't in crossbite. These are all really important things to consider. And at my office, these are complimentary exams. If you have a question or an issue or just wondering or curious, set up an appointment. I would say most kids, 80% of kids, do not need any kind of early orthodontic intervention. There are a set of things that you look for that when there is intervention that's needed. And that's when there's some kind of traumatic occlusion where the teeth are hitting and now you've got recession on the gum tissue because they're hitting in a bad spot and they're torqued or turned the wrong way. If the palate is more narrow on top than the jaws on the bottom, that can cause poor alignment, and the periodontium can become affected in a negative, have long-term consequences. So there are a few things that you look for, but the majority of kids don't need early orthodontic intervention, despite how many little 7 and 8-year-olds, 2nd and 3rd graders you see run around with full braces on. Not always necessary. Most of the time, not necessary. They don't need. Most kids do not need to have early orthodontic intervention. So, is there anything you can do at home besides brushing, flossing, using toothpaste? I would recommend at parents' discretion to add mouthwash. ACT is my favorite. ACT, lots of good flavors. It does have a little bit of fluoride in it, and it's just an adjunct to add to that. If someone is here and has current cavities, I do usually recommend a prescription strength fluoride toothpaste to add to help with those things as well. But if everything looks good, everything, you're doing a great job, there's no reason to add an additional layer of toothpaste that has a stronger degree of fluoride because everything's going well. We want to also look for a few things. What can you look for at home that maybe can set off a trigger like, what is this? Do I need to get in? Do I not need to get in? The first is, and this comes up fairly often, I would say once or twice a week, we have someone come in who's experienced trauma on their tooth. They fell, 2, 3, 4 years old, fell, and now that front tooth is starting to turn dark, or it has turned dark. What does that mean? It doesn't mean we have to pull the tooth out. It does not always mean that. Lots of times what will happen is that dark tooth will actually get darker, but then lighten back up, and you'll see it lighten back up. And again, don't need to do anything. Now, if you lift up the lip and there's a little bubble right above the tooth, a little bubble or pimple, that's a sign, that's an abscess. And in that case, that tooth needs to come out. But just the color in and of itself does not mean that. And so what I like to do is if there is something, the way I've been trained, if there was some kind of trauma, to get a baseline picture of that, because then you can see if it changes over the next 6 months, 12 months, or if something happens where you're now concerned, you can go back and take another image of that and compare the 2 images and see if there's been a change radiographically with that tooth to determine what we need to do with it. And most of the time I would say we don't need to do anything, especially in the beginning. You don't need to do anything, but it's good to have a baseline guide of what to do. And so bad breath, what to do? I get that question probably once a week as well. Best thing is to get a tongue scraper or a tongue cleaner off of Amazon, $10. Get back there on the tongue. That's where that bacteria is being harbored, and to get that off, some mouthwash, but to get that to come off. The brown spots, brown or black little speckle spots, see that as well. That is a bacteria called actinomyces. It's a bacteria called actinomyces, brown or black little speckling, which will change shape and change patterns. It does not harm the teeth. It does not harm the gums. It just doesn't look good. And getting it off, we'll have some kids come in as often as they need to. Parents will notice it's starting to come on again, and you can't get it off very well at all with the toothbrush at home. We actually have to scale it off. It just takes a few minutes, but you got to get in there and just get it off. But it's nothing to be overly concerned about, but it is something that we can take off with an instrument, dental instrument, a scaler. Staining or biting, staining on the biting surfaces, brown or black spots. A lot of times it's just stain. Most of the time I would say it's just stain. And stain is not a cavity. Stain on the teeth or the grooves of the back teeth, the real deep valleys, those ridges and those valleys. Stain does not indicate a cavity, it just indicates a stain. And so can those areas be more susceptible to cavities? Sure, but as long as it's nice and hard, it's not decay. It's something we can watch, but it's not something we have to go and do a filling on. Now, if it's soft and sticky, or there's a hole there, that's a different story. One thing we call them shark teeth, where if you look down here and those permanent teeth will start to come into the back right in here. Those are what we call sometimes shark teeth, where the permanent teeth are erupting on the back and these teeth aren't getting super loose. Most of the time, not always, but most of the time, we have to remove one tooth for the other tooth to come in. Now, sometimes we have to remove two teeth for the permanent teeth to come in, because the permanent teeth are always going to be wider than the baby teeth in the front. And so a lot of times you have to remove two teeth, baby teeth, in order for one permanent tooth to come in. And so just because it's happening on one side doesn't mean we have to do the other side. So if it's just on one tooth, I will just do, depending on how wide that tooth is, I've done just one tooth. I've done two teeth before. Just depends how wide that permanent tooth is, because with the tongue, we'll actually push that tooth forward into the correct position. What we don't want is that those teeth build up and start stacking on top of each other, all these teeth that need to come in, because then you don't have enough space for all the teeth to come in, and you can end up getting an impacted tooth, have other problems that can and should be avoided. Underbite, like this, like that, or an overbite, where this is back, retrognathic mandible versus prognathic mandible. What to do about that? A lot of times you don't do much in the very beginning, 3, 4, 5 years old. You wait to see how the permanent teeth in the front are going to come in. A lot of times they'll come in at the right angle and correct that. Now, if they come in and it's not corrected, then we can look at doing something orthodontically, and that is an indication for orthodontics. The literature shows on that you need to do it before they're about 9 or 10 years old to have the most effect with the sutures. You have a suture going down the middle of the palate. It's called your mid-palatal suture. And you have about 7 sutures in the back that connect the maxillofacial structure. This whole structure is connected by sutures in the back. And so essentially pulling out the maxillary bones, pulling this out and allowing this to stay back to correct that underbite. That's something we look at. And changing in eating or sleeping habits, that's something you look for. Are they complaining? You know, if they're not really talking well, 1.5, 2 years old, and they're just eating different or favoring one side or pointing to their tooth, sometimes there can be a concern with, is there a cavity there? Is there a swelling there and an abscess? And it's something we can take a look at. So those are kind of some of the things to listen to your kids for, pay attention to. So if you see any of these things, call your pediatric dentist, call me, we'll get you in, consultation, do a limited exam, just to kind of, if nothing else, peace of mind, letting you sleep well at night. There is value to that. As I get older, I realize that there's value to peace of mind and just being able to sleep better at night with things. I'm also asked about dental emergency. To kind of wrap this up, dental emergency. What is a real dental emergency? What is not a dental emergency? And so I would say a real dental emergency is your child in pain? That's the first thing you got to ask. Are they in pain, and is it getting worse, staying the same, getting better? If it's staying the same or getting worse, come in. If it's getting better, maybe just see how it goes over the next few years. But if it's getting worse and worse, that would be a dental emergency. And also, is it going to affect long-term what's going on? And you don't always know that. You know, an abscess in the tooth, that's going to be painful. But also an abscess is acidic. That infection is acidic. And you have a developing tooth above or below that infection. And that can start to, that acidic infection can start to damage the developing tooth bud of the permanent tooth. So that's something you want to address. So what are some examples? A cracked or fractured tooth, bumped it, trauma, fell down. I've had many patients call me on the weekends, and I just say, here's my cell phone. I'll go ahead and text you from my cell phone number. Send me some pictures. And most of the time, it's fine. It's not an issue. Sometimes there can be a sharp edge on the tooth. Sometimes it can hurt, you know, with air going through your mouth. Those are things we want to look at. If the child's uncomfortable and it's sharp, we can just smooth that out. Doesn't mean we have to do anything more than that, especially on baby teeth. We're not going to try and build them up and make it look like Hollywood. It's a baby tooth, for crying out loud. So we just want to be able to smooth it out. Now, if it's painful when cold water, cold drinks, doing this we basically just put a little Band-Aid on it. Again, not going for Hollywood on baby teeth. Permanent teeth, a little different deal. We just want child to be comfortable, want mom to be comfortable, want everyone to be happy, and mostly to get them out of pain. A tooth that gets knocked out, you want to make sure that the root and the tooth part is both knocked out, and so that it's not broken off. The crown part, the part you see, isn't snapped off, and then you have a root still up there. That most of the time we'll leave it there, but it all depends. It all depends. Want to get a picture of it to see what's going on. If there's any kind of facial swelling, I'm not really big on giving antibiotics. I'm not a big antibiotic guy, kind of more natural, but in the event that there is facial swelling from an abscess, I will give an antibiotic if there's facial swelling. There's different planes in the face, canine spaces, different planes. You don't want an abscess to spread and go up into the canine space near the eye. You don't want it to go down into the throat area. So if there is a facial swelling, I will give an antibiotic. But as long as there's no facial swelling, that infection is contained to the tooth. Removing the tooth is the etiology, or where that bacteria is coming from. Removing the tooth will do the job. Even braces can be an emergency. I mean, I've had patients call our emergency line that are not patients, especially during the COVID time, because they can't get a hold of their regular dentist or the pediatric dentist, and I'll come in and see them. If nothing, just to get them out of pain. Pokey wires, other orthodontists weren't open, and so they called me, and I came in, no big deal, cut the wires for them, trimmed the wires, got them out of pain, pokey wire, or facial swelling. We did have one with an abscess, facial swelling, came over from Children's Mercy, that we were able to treat. They called, I think it was about 9:30 at night on a Sunday. Grandpa, mom, and child came over, and did have some facial swelling, had an abscess, big abscess, been there for a while, a few days, and we were able to get that tooth out and take care of them. Came back a week later, everything looked awesome. They were super grateful, so it worked out really good for everybody. Getting a hold of me for any of these things, especially these after hours, emergency, things like that, I probably do something that not many dentists in the country do. Our emergency line goes straight to my cell phone. So if you need to get a hold of me anytime, I say day, night, weekend, holiday, 3 in the morning, call our emergency line, you hit 1, it goes right to my cell phone. I'm happy to do that. It's part of my job. It's what I consider being dedicated, my ethical and moral, commitment to the community here is to always be available, and I love it. I love it. It's what I do. So I'm happy to do that, but I am available at pretty much all times. If I'm not in town, still same thing. You call, it goes to my cell phone. I have another doctor who will be on call, another pediatric dentist who will be on call to help out with that as well. So hope some of this information was helpful. Even if you skipped through it, hopefully you found something good. I know it was kind of long, but being able to address these points that moms are really asking a lot about on social media to us, different forums on Facebook, Instagram. These things are important to just have a better understanding of. So next time I want to talk about a few different things as well. We'll talk about further growth and development, first kids dental visits, anxiety, special needs, how do we deal with these things, what's the best type of sedations. Laughing gas, that's a sedation, that's a mild sedation. And then what do we do if the child doesn't do well with just laughing gas in the office and some Novocaine? What are the next steps? What's the best option for your child? Because we don't want them to be traumatized, but at the same time, we want to be as conservative as possible. If you do have any questions, PM me at sweettoothpdo.com, at sweettoothpdo. Our website is sweettoothpdo.com. Again, at sweettoothpdo, and our website, sweettoothpdo.com. And if you need anything, just reach out. Again, you can get a hold of me anytime on the emergency line, and on social media, or at our office. Call us. Thanks a lot. It was a pleasure. Hope to see you guys soon.